Warfarin. Introduction. Warfarin is a blood-thinning medication. It decreases the ability of the body to form harmful clots. Usage. Take the dosage of Warfarin prescribed by your doctor, always at the same time of the day. Your doctor will give you enough Warfarin to thin your blood without thinning it too much. If the blood is not thin enough, blood clots inside the blood vessels and heart may form. If, on the other hand, the blood is too thin, you risk a longer bleeding time. Longer bleeding can result in an excessive loss of blood if the person is involved in an accident. Severe blood loss can be fatal. The solution is to take the amount of Warfarin requested by your doctor and to check how thin your blood is on a regular basis. Instructions. To keep your blood as thin as it should be, you should keep your eating habits regular. Keep your exercise level regular. Check with your pharmacist and doctor before taking any new medications, especially over-the-counter medications and antibiotics. Make sure to tell your new doctors or nurses that you are on Warfarin, especially if any type of surgery or injection is contemplated. Tell your doctor if you are pregnant or may become pregnant. If you miss a dose of Warfarin, do not take an extra pill to catch up. It is important to keep the amount of vitamin K.
With the Cardiosaurus Heart Minute, and today I'm with Chris Cannon, and we're talking about some of the new stories that have come up in the last couple of weeks that are of interest. One of those is a story in JACC, which concerns a comparison between the thrombin inhibitor Dabigatran versus the anti-10A agents apixaban and rivaroxaban. This was an indirect comparison, and it's really difficult to understand with all of those comparisons in the previous trials exactly what kind of a conclusion, I guess, is you can reach with this. So they tried to put together all of these three agents and compare them against warfarin. You wrote an editorial on this, Chris. What's your take on this?
Well, it's a very hot topic, obviously. We have three new drugs. Each trial showed benefits over warfarin, and so we then are asking, well, which one of these should we use? And so it's very tempting to compare to that one common denominator, the warfarin. I think what's clear is that each of them has advantages, but when comparing one agent to the other, the problem is that the trials do have differences between them. So some have patients with very high CHADS risk score, others have the full range. There's also differences in how the warfarin was managed, with differences in the time of therapeutic or time in therapeutic range of the patients in the warfarin group. So you can't attribute all of the difference seen relative to warfarin to the new drug. Some of it is the control group in the population.
Right. It looks to me like probably we're still going to have to wait for direct head-to-head comparisons between these agents. I doubt, candidly, that will ever be done. But until then, we'll have to do the best we can, probably going back to the original studies. Would you agree?
Exactly. I think, these are all large trials, and so each of them individually provides us with very good evidence for what the efficacy and safety is in preventing strokes. It's often less bleeding, certainly fewer hemorrhagic strokes, so I think some real advantages of the new agents, but relying on the individual trials is probably the right answer.
So, good agents, but the jury's still out, and we'll just have to wait and see. Thanks.
FDA with approval of Dabigatran, an oral thrombin inhibitor for prevention of stroke in patients with atrial fibrillation. This has been a highly anticipated new approval and indeed the first approved oral anticoagulant in more than 50 years. Warfarin, as we know, is our mainstay of therapy, but it is a huge headache to use in that it is so variable with the interactions with food and other medications and the incumbent monitoring that is required. Dabigatran is an oral thrombin inhibitor that's been studied at 2 doses, 150 milligrams that was approved, and 110 milligrams was also studied in the RELY study as compared with warfarin for prevention of stroke or systemic embolism in patients with atrial fibrillation. At the 150 milligram dose, Dabigatran was superior in preventing more strokes or systemic emboli than warfarin. It also had a lower risk of intracranial hemorrhage, which may relate to less excessive anticoagulation with warfarin. But it was seen to have an equal rate of major bleeding overall. Now, interestingly, a lower dose of 110 milligrams was studied, had equal efficacy to warfarin, but was safer, and yet that dose somehow was not approved by the FDA. And so we'll be looking for some answers as to why not. But in any case, the higher dose of 150 milligrams will do a better job in preventing strokes in AFib. Now, there are different side effects. Obviously, bleeding is an issue with any antithrombotic agent. Dabigatran also caused some dyspepsia because it's absorbed in an acid environment, but otherwise was pretty well tolerated in the studies. Now, there is not a need for routine monitoring, and so this will be a big switch.
Presented by Drugs.com. Today we are reviewing Pradaxa, generically known as Dabigatran. The FDA approved Pradaxa, an anticoagulant, in October of 2010 to reduce the risk of blood clots and stroke in adult patients with atrial fibrillation not due to a heart valve problem. Patients with atrial fibrillation, or AFib, have irregular heartbeats and are at a greater risk of developing a blood clot that may lead to a stroke. Pradaxa works as a direct thrombin inhibitor and blocks the conversion of fibrinogen into fibrin. This action helps to prevent the formation of a clot. Unlike warfarin, Pradaxa does not require regular blood tests to check the therapeutic effect. However, there are some safety concerns. Pradaxa should not be used in patients who have active bleeding. Kidney function should be evaluated prior to the start of Pradaxa therapy, and in some cases yearly thereafter. Pradaxa should be stopped for certain procedures or surgery, but should be restarted as soon as possible. Because Pradaxa is an anticoagulant, it can also lead to serious or fatal bleeding. Pradaxa should be used cautiously in patients older than 75 years of age, in kidney impairment, and in patients with a history of a stomach ulcer or bleeding. Other common side effects include dyspepsia, also known as heartburn, and other gastritis-like symptoms. In patients with kidney impairment, reduced doses may be needed. There are important drug interactions with Pradaxa. Rifampin should not be used with Pradaxa as it may lead to a decreased therapeutic effect with Pradaxa.